Welcome to the Explainer. Today, we're diving into two esophageal motility disorders that are, well, notorious for being a real diagnostic headache: distal esophageal spasm and hypercontractile esophagus. We're going to break it all down: how to spot them, how to diagnose them, and most importantly, how to manage them.
All right, let's just jump right into a classic clinical puzzle. You've got a patient with chest pain. The whole cardiac workup comes back negative. So you do an upper endoscopy, an EGD, and nothing. Structurally, everything looks totally normal. This is that exact moment, that clinical crossroads, where you have to start thinking, okay, maybe the problem isn't what the esophagus looks like, but how it works. And that's where these two culprits come in. We're going to really zero in on distal esophageal spasm, or DES, and hypercontractile esophagus, HE. They can get a little confusing for sure, but they are major players when you're dealing with non-obstructive dysphagia and that tricky non-cardiac chest pain.
So let's start with the basics, the clinical problem. What brings these patients into your clinic in the first place? It really boils down to two big things: dysphagia, trouble swallowing, and that really frustrating non-cardiac chest pain. Okay, so how do we actually figure this out? How do you go from just a suspicion to a real concrete diagnosis? Well, that brings us to our next step: decoding esophageal motility. And the key, the absolute cornerstone, is a test called manometry.
The gold standard here is high-resolution manometry. You see, an endoscopy just gives us a look at the anatomy, the physical structure, but manometry shows us the physiology. It lets us measure the pressure and, crucially, the coordination of every single swallow in real time. It's literally how we see the squeeze.
And to interpret that data, we use the Chicago classification, which gives us this really nice, clean two-step logic. Step 1, look at the bottom. Does the esophagogastric junction, the EGJ, relax like it's supposed to? We measure that with something called the integrated relaxation pressure, or IRP. If that's normal, meaning there's no obstruction, then we move to step 2. We look at the peristalsis itself. And this is where we find DES and HE.
All right, now for the main event. Let's put these two disorders head-to-head. I think seeing them side by side, comparing spasm versus hypercontraction directly, is really the best way to get a handle on what makes them different.
But first, a quick reality check. These are not common diagnoses. I mean, look at this. Even in a specialized center where patients are sent specifically for motility testing, DES and HEO only make up about 2 to 4% of cases. So you really need to have a high index of suspicion to even go looking for them. Okay, so here's the core difference: the why. Pathophysiologically, these are two totally different beasts. Think of DS as faulty wiring. The inhibitory signals, the stop and coordinate signals, are failing. That leads to this chaotic, uncoordinated premature mess. In total contrast, HE is all about brute force. The excitatory, or go signals, are just cranked up to 11, leading to these incredibly powerful contractions.
And this is what that looks like on our tests. For DES, the smoking gun on manometry is premature swallows. At least 20% of swallows have to have a distal latency of less than 4.5 seconds. And that classic corkscrew esophagus you see in textbooks, yeah, you almost never actually see it. For HE, the signature is that raw power: hypercontractile swallows with a distal contractile integral, or DCI, over 8,000. The timing is fine, it's just way too strong. Okay, so now that we've got that comparison down, let's piece it all together and walk through the logical diagnostic pathway you'd actually follow in the clinic, from the moment the patient walks in the door to getting that definitive answer. The approach is always systematic. You start with the upper endoscopy and biopsies. You have to. Your job here is to rule out all the common stuff first, things like strictures, tumors, and especially eosinophilic esophagitis. Only when you've confirmed it's not one of those do you move on to manometry to actually measure the function and nail down the specific motility disorder. And even then, before you stamp that diagnosis on the chart, you've got to think about the mimics. GERD can do this. We already mentioned EOE. But please pay special attention to opioid-induced esophageal dysmotility. It's getting more and more common, and on a manometry tracing, it can look identical to DES or HOE. So a really good medication history is absolutely critical.
So you've done the workup, you've ruled out the mimics, you've made the diagnosis. Fantastic! Now what? How do we actually make the patient feel better? Let's get into the management plan.
Now this is probably the single most important slide in this entire explainer. The goal is not to make the manometry plot look pretty. I'm serious. The goal is to make the patient feel better.
We are treating their dysphagia and their chest pain, not the numbers on a report. We treat the patient, not the plot.
So, our first-line therapies are all about targeting the specific problem. If dysphagia is the main complaint, we go for smooth muscle relaxants, things like nitrates or even something as simple as peppermint oil, which can help relax the muscle. But if chest pain is the dominant issue, we're thinking about visceral hypersensitivity. That's where low-dose tricyclic antidepressants come in. They act as neuromodulators, basically turning down the volume on those pain signals.
Now, what if the meds just aren't cutting it? For those refractory cases, we have to escalate to more advanced, more invasive therapies. We can do an endoscopy and inject botulinum toxin to temporarily paralyze the overactive muscle. Or, for a more permanent fix, we can actually cut the muscle with a myotomy, either endoscopically with a procedure called POEM or with traditional surgery.
So let's tie this all together. What's the big takeaway here? These are symptom-driven diagnoses. That's it. You identify the symptoms, you use manometry to confirm the problem after you've ruled out all the mimics, and then you climb the treatment ladder with one single-minded goal, getting your patient some relief.
And I'll leave you with one final thought, a little clinical pearl to keep in the back of your mind. These spastic disorders don't always stay the same. A small but very real percentage of patients with DES or HUS can actually evolve over time and progress to full-blown achalasia. And that really underscores why long-term follow-up is so important, because a diagnosis today might just be one stop on a much longer journey for your patient.